So Matthew Lewis isn't with us today, but Victoria Palmer is, and Elise is accompanying her. Victoria is the director of the Alive National Centre for Mental Health Research Translation. And I'll let you explain more.
I can do that today.
Elise is a lived experience researcher at the University of Melbourne, and she has 20 years of lived experience of mental health issues. Yep, thank you, Elise.
I tried many times even to not even turn up.
Do you want to step up?
To not turn up to see if Elise would present, but preference is that I'm presenting and driving the slides, and if you feel like you'd like to chime in at any point in time, Elise, because I know Elise has been working with the data and all of the program for so long, it would be terrific to hear. So I presume if I click, it's coming on up. Lovely. Back here a bit more. A little bit about me. So I'm Victoria Palmer. I'm located at the University of Melbourne, as Faye said. I'm a Professor of Primary Care Mental Health, and I'm also a Professor of Co-Design in that role as well. And I'm here with Elise, and Matt runs our trial, and we're talking about the Healthy Hearts study, which was funded by the National Health and Medical Research Council. Elise has been working on the team and actually came through from being part of our co-design process into the shifting landscape of what is co-design and what is co-production to now being a part of the team and starting to think about how we analyse the data. I'm someone with lived experience as well. I bring that to the table when I do my co-design work, and I offer that to just relax us while we're up here a little bit too. So the team is large and mixed, multidisciplinary team, as all of these things need to be. And just noting that we don't do it on our own. We have a wonderful research fellow who's a trial manager, and we have coordination support, and we have a research nurse, and we have our lived experience researchers and data managers. So it's a broad group of people working on this project. Now, I don't need to tell anyone this story here. We've heard it this morning, but, people who live with mental distress are more likely to have a higher risk for cardiovascular disease, develop that at a younger age and at a much younger age than what we see in our current cardiovascular risk screening tools as well, and higher likelihood of factors that underlie cardiovascular disease as well. The other issue is that all of these causes involve a range of systemic, relational and individual factors, and primary care, in our view, is key to addressing these. This study, the evolution of this study was from a previous project that was about co-designing a service improvement in the core. It was called the CORE study in community mental health services, and what we discovered from working through that process with people was that many people actually were attending their GP to have support, but obviously the gaps in meeting people's needs are really quite wide. So we saw this opportunity to work in the primary care space to think about how we could work better with GPs and bring that to the table. But importantly, we need to break down the silos between primary and secondary care as well through that process. And the last point here is the most key. We have lots of single disease focused approaches and single factor approaches to everything. It's really important to understand that this particular trial is multifactorial, and it's looking at multiple issues that people want to identify and drive with, and then how we might do that in a multifactorial and combined approach to pharmacological and non-pharmacological approaches. So we thought we better ask people what they would want. You can see Elise here in the photo of one of our co-design sessions or meetings in the process of talking about our Healthy Hearts model, and our basic approach was to ask people using co-design. And it's important, as I mentioned before, around how we came into being of the trial in terms of building on a previous study, that we had two big studies that had ended at the same time. We had the core study that had ended, and we had a big longitudinal study for 10 years of primary care looking at depression services and people's experiences. So when those two projects were ended, I took the opportunity to reflect on what we could be doing better in our work and what we could be doing better in our research program. And that led us to establish what we call the Co-Design Living Labs program, and that's an end-to-end research design to translation model. And so through that process, we started to invite people, when our projects have finished in the mental health space, into the Co-Design Living Labs program and say, people bring their lived expertise to our research studies all the time. But on top of that, over time and being engaged in processes over 5 or 10 years, people also develop some research expertise through the process. And so we wanted to harness all of these elements together and build a model where we could have people embedded when we are doing grant proposals or looking at models of care, so on and so forth. So the Healthy Heart study that I'm talking about today has a long trajectory. You can see there 2016, and I think also the Co-Design Living Labs program has a long trajectory. And much like Chris was saying earlier, that means it's changed over time as well. And we've changed our models and our ways of working. So we started out talking with people in continuing care units about, here's some Healthy Hearts information, here's information about cardiovascular risk, what do you think of it? And really starting to get that feedback about, you know, what works for people in terms of communicating information and all of those elements. Then we convened and talked about recruitment strategies. We also then talked about how we might need a checklist or a conversation aid, similar to what Caroline was talking around. And we also co-developed a heart health information booklet. Then we took that back to some simulated co-design sessions around what it would look like when the research nurse was at the table, also trying to support and provide cardiovascular risk assessments and care as well. Then we had a pandemic, which was really inconvenient because we'd just geared up to get started, and we'd recruited a number of different primary care sites and actually had a few people enrolled into different parts of the study. And then with the pandemic, we had to pause for over a year. So during that time, we then moved to a virtual model of care and starting to think about how will we be able to deliver some of the issues or deliver on the issues that need addressing around addressing heart health at scale, and to think about web real-time communication as a way forward. So from 2021 into 2022, we've adapted. We've undergone more co-design through that process, and we are underway again. In terms of that Co-Design Living Lab membership, just a little take-home for you all, it is now being also scaled nationally as part of our Mental Health Research Translation Centre. We do have over 2,000 people who are members, and you can see that people are starting to grow across the different states and territories. When we undertook the co-design with our Living Lab members, we worked with people typically for about 1 to 2 hours. We typically had up to about 6 people, and we'd go in and we'd share the background of the study. We would listen to people's stories because that's super important. I can see your words there, Elise, and you can huddle over a bit closer in case you want to say anything going forward. And you know, we discuss the materials, we'd look at the touch points, which is important in our model of co-design, and we'd look for design principles out of that of what's needed, and then we would undertake more co-design. And here are 2 big tables that are forthcoming, which will be coming out in a paper that Elise and Jeremy are at the moment leading for and with the team. And here we've tracked, you know, how we've gone through that process of co-design from 2016, 2017 to 2018, and what co-design approaches we've used, what outcomes we're trying to inform, and then the illustration of co-design principles that are in action in our view and in our model, of course, because of course everyone does do these things slightly differently. You can see here again going through 2020 into 2021, again, the co-design approaches that we've used, the impacts on the intervention design, and the illustration again of those co-design principles in action. So in effect, what we landed on was this Healthy Hearts intervention that would enable primary care to do a better job of identifying people who may have increased risks, bring people into the study and start to systematically deliver healthy heart checks for people and with people about the risks of developing cardiovascular disease. So people then attended a healthy heart action plan appointment, or they're going to do that, and then the results are reviewed, discussed with a nurse, all using the web real-time communication platform. Again, we're using a conversation aid approach. That's what we heard was beneficial for people, and the goals are set to try and improve lifestyle factors. And the other part, and why this trial is also called assertive cardiac care, is that we found that the assertive community care model and the principles underpinning that provide a very effective way forward. And that means that we need to have constant check-ins and touch points with people along the way. So this is actually a year-long intervention. It's not a 6-week program or a 6-month intervention as we always see in randomised controlled trials. It runs for 12 months, and after that healthy heart action plan is developed, then people have regular touch points with the team. They have either an SMS reminder or positive messaging, and they have a phone call to check in as well. So there's constant connection. Frequent is what we've heard, not too much, but just enough to remain in touch. So some of the things that resulted out of the co-designed outputs were around simplifying the materials. No surprises there. Researchers tend not to engage in plain language all the time. Simple and clear and achievable goals, continuing support to achieve those goals and that regular connection, and being very deliberate about that connection. Peer support outside of the study, peer support was also sought after, but it was outside of the capacity of the study as it was funded at that point in time. We always like to document what's on the table for people though, and to take that forward into the future research. And again, people wanted home-based dedicated support. So again, speaking into that assertive community treatment model that's delivered in the community, very deliberative, regular check-ins, but also in the home context is preferable. So we had the conversation aid that was co-designed to prompt discussions around the risk areas. It had an underpinning theory of motivational interviewing, and the way the questions are asked are all very deliberate, and it was very iterative so that it became more user-friendly and appealing to our members who we refer to as co-designers. And this is just to demonstrate for you that in action. So you might be remembering parts of this, Elise, or not. But, you know, I went from circles and round things are the things that I like, and putting together some ideas about how might we talk about heart health in a way that's, you know, engaging for the person, and could we develop spider maps so that we know the areas that we might need to identify, so on and so forth. We iterated on that a couple of times with people, but then to the other side, with the conversation aid that you see, people wanted a more simplified and engaging approach for what they were looking for in terms of the areas that they felt they could change to have better heart health. And so we landed on what you see on whatever side you're looking at in terms of this more structured format. And now that is delivered through the trial and through the Healthy Hearts intervention. And as I was saying, the questions at the top, motivational interviewing informed, and that runs as a thread across the whole program of work. We took, when we did the adaptations for the virtual care platform, we went through a process of looking at how might we need to build in support, or how might people like to engage with the model? What would people need along the way? People talked about ways to build rapport with their GPs ahead of time, needing to be well prepared for the GP visit ahead of time, and not getting any surprises along the way. So really having a lot of information about what you would want along the way leading up. And also really focusing in on goals. I know that some people don't even like the language of goals, but starting to think about, ways that you can revisit them, and really starting to think about the barriers towards that. And that's one of the strengths, I think, of the Healthy Hearts model that we landed on, is that people can reevaluate their goals during that 6-month follow-up, where they're getting the check-in with a nurse and with the GP and starting to look at, well, how's it going? What could you change, and how could we help along the way? This is just a screenshot of the virtual care platform. You can see that red button down the bottom there starts and ends the session, so to speak, and the black would normally be the two people who are looking at each other in real time. And you can see just in those tiny little blue dots there, that's the different component parts of the intervention. People talk about their risk summary together, then they undertake the conversation aid, undertake goal setting. Very important, people said to us way back in 2016 at the continuing care unit, I want something to take away for myself and take home and put on the fridge and just have in a simple size, object that I can look at and refer to over time. And so we've maintained a commitment to that as well. Reflections on the co-design activities. So someone else might put these together for us. So the ideas from us, from our research team, have been challenged and modified with input from the Living Labs or the co-designers. We've now embedded more lived experience researchers within the team, some of whom have been in the co-design processes. And co-design facilitates change and results in those significant changes to the process and outcomes, some of which I've demonstrated here, but others are more deeper and require more time to talk about. The co-design processes overall do receive great feedback, and people generally share that they enjoy giving those insights into the issues being co-designed. There are limitations of cost and time. Obviously, the peer support part in the process, for example, doesn't mean that everything can be taken up and followed through. But we always start all of our co-design sessions with expectations around what we can and can't change. And then we always suggest that we all put everything on the table, because down the track, we might be able to pick up on it in the future. And as a program overall, we're really grappling with giving more consistency and feedback, and in particular, the links between how the co-design has led to either the changes or the improved outcomes as well. And that's something that we're working on over time. To the future, being flexible and open-minded and discerning as researchers.
That's easy, isn't it?
Aiming for shared ownership of what's co-produced with all co-designers. So we do need to think about how and what does shared ownership mean and look like, and how do we work within some of the structural constraints that we have around project funding. We need to continually improve, and I think over time, fair to say Elise has been immersed in early data that we collected in 2016 and 2017 and 2018, and noticing that shift in the program and the ways of our working too, and how we've had to think about things more explicitly and bring forward things that are implicit to being more explicit. And as co-design becomes more embedded, it's going to become easier, apparently, and more integrated in our thinking. So we do need to have those explicit ways of working, and there must always be attention to that power sharing and active involvement in decisions and the creative outcomes. And I think here we're just ending on the message around co-design is also about shaping as much as it is about making, and those are critical components that need to come forward. And we do recognise there are those challenges in co-design. You land at a point and then the people take it off and do the design work and then bring it back, and we need to work on ways that that becomes more and more embedded over time. So thank you for listening to parts of our story, even though I'm standing here. And if you want any more information about the study, there's some details there. As I said, this is part of our work that pre-existed the Mental Health Research Translation Centre, so I've very much focused today on talking about that. And if you've got questions about the centre and all those other aspects, do feel free to ask in any of the breaks. So thank you, Faye. Probably should have some time spare. Thank you, Elise.
I think it's incredibly important that we stay true to co-design, that it's deep co-design. And at Flourish, we say that true design starts with only one question. What are the questions that we need to ask? Because if you're asking the wrong questions from the beginning, then you'll be getting the wrong answers, the wrong outcomes will follow those wrong answers. So true co-design is deep, it's complex, it takes time, it takes generosity of spirit, it takes true equal respect between all of the participants in the co-design. Very true respect. Flourish Australia, we have our co-design guidelines. I can't remember the exact wording, but one of the accountabilities, Accountability 8, includes who the stakeholders might be. And our co-designers who wrote the co-design guidelines said that they could be people, for intergalactic people, people from other universes, people, you know, things like that. Because that was their experience and that was included in our co-design guidelines. Co-design, true, deep co-design is brave. It's messy and it's brave. If it's not messy, it probably isn't co-design. And co-production is incredibly important. I'd really like to, Carolyn, if we can get some time, I'd really like to talk about, you did the co-design and then sent it out into the clinicians to see how they would utilise it. Well, then co-production is as important in the utilisation of that as co-design.